Hi guys, welcome back. The next topic we're studying is pleural effusion slash hydrothorax, and one of the radiological findings, very characteristic ones that is seen in this condition, and in fact is one of the earliest radiological findings seen in pleural effusion is the blunting of the costophrenic angle. You will notice that due to gravity, the first fluid will accumulate in this area, which I'm marking as area number 1, that is costophrenic angle, and then subsequently the fluid will be accumulating in area number 2, that would be called as cardiophrenic angle. And in the exam, we just need to pick up those words. That is, costophrenic angle is going to be the first one to be obliterated in a person with minimal pleural effusion. It usually requires about 200 ml of fluid to cause an obscuration of the costophrenic angle. And usually by 300 ml or so, clinical findings will also be appearing that I'm going to describe in the subsequent part of this video. A second radiological finding that I would like to draw to your attention is this very beautiful Ellis curve. The radiology people are either going to use the term Ellis curve to describe this concavity, or the second one that's going to be used to describe this is called as meniscus sign. And though you are going to read about meniscus sign even in intussusception, even in a couple of other conditions. So what I would like you to remember for the exam primarily is this concavity. And the reason for this is that in the later part of this video, I'm going to show you a convexity in this area, and that's going to change the entire diagnosis. So I would like to keep the mystery wrapped up at the moment, and when the time comes, I'm going to show you an X-ray where there's a convexity present. Let's now focus on some normal baseline information as well. You're aware from your basic sciences classes that the normal amount of pleural fluid would be something in the range of about 5 to 15 ml, and that is for lubrication purposes. Now, this pleural fluid is a transparent fluid, it's a clear fluid, and this would be a ultrafiltrate that would be coming up from the capillaries that would be lining the pleura. And as a result of it, I can say that in case it's gonna be turbid or if it's gonna be purulent, that would mean development of empyema, for which specific treatment would be discussed. Then when we evaluate the pH of the pleural fluid, it usually is in the range of about, you know that in the blood, the pH would be 7.35 to 7.45. But when it comes to the pleural fluid, the pH usually is in the range of 7.60 to 7.64. And why it's important for you to know that if there is an acidic pH given here like 7.3 or 7.4, which is lesser than the values that I've told you, then acidic pH of pleural fluid favors possibility of an exudate. That's going to be an inflammatory fluid accumulation in the pleural cavity. Now, apart from the pH, he can also ask you regarding the protein values. And what you need to remember is that in the pleural fluid, the concentration would be about 1 to 2 gram. And the importance of knowing this information is once again that if there's going to be an exudate, if there's going to be inflammatory condition, if there's going to be fibrin present, I think I made myself clear, any inflammatory condition is called as an exudate. For example, malignant pleural effusion or empyema, which is pus in the pleural cavity. Due to inflammatory causes, the protein values are going to be higher than the normal value that I've described. Now, as far as glucose values are concerned, this is going to be same as that in the blood. Unlike in the CSF, if you go through the CNS section, I've told you the CSF sugar is 2/3 of the blood sugar. But when it comes to pleural fluid, the glucose is same as that of the plasma glucose. And the importance of knowing this is once again that in case you are getting pleural fluid sugar to be lesser, that again signifies inflammatory cause. Usually with respect to malignancy or with respect to a parapneumonic effusion, that person is having pneumonia also in a pleural effusion, translating into a empyema, which is pus in the pleural space, the sugar values are going to be dramatically reduced. Another parameter which is always to be remembered is LDH, lactate dehydrogenase. Normally, we study about LDH with respect to RBCs, and you are aware that if the RBCs will break down, LDH in the blood will become elevated. So mostly in hematology MCQs or in pathology, they'll teach you that one of the evidence of hemolysis, there are multiple evidences of hemolysis, but one of the evidences of hemolysis is elevated LDH. But today we talk about LDH in the pleural fluid as well, and the concentration of this would be about 50% of whatever is present in the plasma. And now putting 2 star marks here, that is with respect to the protein values and the LDH values. And I would like to tell you that these 2 parameters are included. Protein in the pleural fluid and the LDH in the pleural fluid are included in Light's criteria. Though I'll be talking more in detail with respect to Light's criteria in the later part of the discussion, but I would just like to sensitize you at the moment that what is the functional Light's criteria. They're used to differentiate between whether it's a transudative fluid or it's an exudative fluid. And exudative, I gave you a heads up, means inflammatory fluid. So every time there's going to be a cancer, if there's going to be tuberculosis, there's going to be paraneumonic effusion, any inflammatory cause would be having elevated LDH and elevated protein. So the main function of studying Light's criteria would be to differentiate transudative variety of pleural effusion versus an exudative variety. Having said that, I would also like to state that in one of a different video, I've talked about Light's index. That is a parameter that is used to evaluate the severity of pneumothorax. Or he will just put up, Light's index is used for evaluation of, your answer is pneumothorax. If he says Light's criteria are used for evaluation of, then the answer would be the topic of interest, pleural effusion / hydrothorax. Now the question arises that if I'm going to be having a person who's having a minimal pleural effusion, then how much fluid would be usually required to cause a minimal pleural effusion, and how can I be diagnosing a minimal pleural effusion? So let's look at the data that one has to remember. Most of the time, minimal pleural effusion would be when about 50 ml of fluid. I gave you normal values like 5 to 15. You can take an average of 10. Now, if the amount of fluid goes up to something like 50 ml, we'll call it a minimal pleural effusion. And one of the methods by which we can check out that there is a minimal pleural effusion present in a patient is a standard X-ray decubitus. And this X-ray lateral decubitus, because the person would be lying on one side, turning on one side, so the fluid will gravitate to that side and the fluid can be seen. But the problem is, one, with respect to the positioning of the patient and then getting the X-ray beam to focus exactly on that area. I mean, if there is lack of skill on the part of the radiographer, because see, radiologist is not going to do the X-ray, it's a radiographer and they may not be very skilled. So there's a high probability that during the positioning part, if the person is not positioned properly, this can absolutely be missed. I do not want to miss this. So what are the other ways by which I can be doing it? There are two ways, and even the radiologist would have told you that one of the ways to get about identifying a minimal pleural effusion is a CT chest. Having said that, I would like to add from a clinician's perspective that ultrasound chest is very, very good for detecting a minimal pleural effusion, but it's not going to tell me the cause. Because suppose it's a tumor, suppose it's a adenocarcinoma, which has contributed, because adenocarcinoma is a peripheral lung cancer, so it will irritate the pleura and cause a pleural effusion. So I would say ultrasound will tell me it's a pleural effusion, but ultrasound will not be able to pick up a lung tumor, no? So he says that it depends on the clinician's decision whether he wants to write a ultrasound chest or whether he wants to write down a CT chest. You see, suppose in the exam, in a clinical based scenario, he starts giving a history as well. He mentions that the person is having cachexia, which means extreme weight loss. There's mention of clubbing in the fingers. There is hemoptysis. So if you are Pankos tumor-like manifestations, Horner syndrome described. So if there is going to be features which are suggestive of lung cancer in a patient along with cough and also talks about a smoker, then you will be writing CT chest. But on the other hand, suppose in the casualty a patient has come and I want to evaluate whether this chap is having or not having a pleural effusion because he's having breathlessness, ultrasound chest would be more than sufficient. So what he says is that depending on the decision of the clinician, any of the two can be written. Suppose you are stuck in a question where there is no clinical history given, that one-liner questions that sometimes come in NEET PG, and they just say that, or in FMG exam also, they say what is the best way for minimal pleural effusion, then you can answer safely as ultrasound chest. But as I explained to you, that if there's going to be history suggestive of a malignancy, then pleural effusion obviously can be picked up by ultrasound, but the tumor cannot be picked up. For that, I need a CT chest. Now, as I was saying right in the beginning, that there is a blunting of the cost of running angle. So most of the time when the fluid goes up to 200 ml in the pleural space, that is when this blunting of the pleural space would start developing. So I'll just use a different color to highlight that. This is what I'm saying. I mean, the cost of running angle will start getting obliterated, and then the fluid will keep on increasing. So let me now increase the amount of fluid here. I've tried to show a bit of concavity as well while I'm doing this shading. That is for the Ellis curve, which I was explaining to you. And the importance is now at this moment that the lung tissue is getting compressed. So there is bound to be clinical findings, like in this area where I'm putting the star mark. If I'm going to be doing an auscultation, I may be having difficulty in appreciating breath sounds. They might be inaudible. I mean, the breath sounds are there, but I may not be able to hear them because there is fluid covering the lungs. So especially in the infra-axillary areas, in the infra-mammary areas, it might be written inaudible breath sounds as well. If I'm going to do percussion over this area, there's going to be stony dull percussion node. So the point to be remembered is that when do clinical features appear? Clinical features appear when there are approximately 300 ml of fluid in the pleural space, and then the obscuration of the complete of the hemidiaphragm. I mean, this fluid is bound to increase, and if I'm just going to try and draw an X-ray which was identical to the one that was initially shown to you, let me just make that Alice curve with that beautiful S shaped that I was talking about. It may not be an exact S shape for you because it's gonna be a 2D, right? So actually the textbook will describe Alice curve as a S, S shaped curve. But at this moment, all I can say is in a 2D, it might look like a concavity itself. So what you can now see in this X-ray where I've done more shading would be an obscuration of the hemidiaphragm on a chest X-ray, and this would be visible at about 500 ml. So let's do a quick recap with respect to these values: 200, 300 and 500 value based questions. That's going to be blunting of the costophrenic angle. I mean, blunting of costophrenic angle will be present in minimal pleural effusion also, because I get a lot of queries from doctors saying, would you not get a blunting costophrenic angle in minimal pleural effusion? Yes, I'm going to do it, or yes, I'm going to find it, but then it may not be visible on a routine PA view. So that is why we were talking about a special position, lateral decubitus. And as I explained, that if a radiographer who's not, 10th pass, 12th pass most of the time, or like maybe might have done some qualifications, but then they do not understand the intricacies like you and me do. So there's a high probability that you're doing a test which is dependent on the skill of a person which you can't control. So that is why, the newer investigations make importance. But once the amount of fluid increases 200 ml, that's when even in a PA view, this blunting of the costophrenic angle that I've explained to you, this is going to be a data which is going to be valid for the standard PA view. Otherwise, costophrenic angle is blunting of the costophrenic angle is present even at 50 ml. But on a PA view, this is at 200. Clinical findings like stony dull percussion node will become more obvious at about 300 and more, and then obscuration of hemidiaphragm at 500 ml. Most of the time, tracheal shift. A lot of guys focus on the tracheal shift part, saying, sir, you did not say anything till now regarding tracheal shift. Like when I take a live class, the query, sir, you did not say tracheal shift. Radiology people always begin by telling us pleural effusion, tracheal shift will be contralateral, tension pneumothorax would be contralateral, lung collapse would be ipsilateral. Guys, in reality, the tracheal shift will appear when as much as 1 liter of fluid is present in the pleural space. So the symptoms of dyspnea would be very, very pronounced by that particular point of time. So clinically speaking, yes, you do have a same-sided tracheal shift with respect to lung collapse or idiopathic pulmonary fibrosis. You have a contralateral shift of the trachea with respect to pleural effusion or pneumothorax. I'll repeat the data once again, though at this moment I'm not writing it because that's baseline information and has been told in the earlier part also. In a case of pneumonia, it's going to be central, but in pleural effusion, there is fluid. Whereas with respect to pneumothorax, there's positive pressure. Therefore, in tension pneumothorax and pleural effusion, because the word is positive pressure, the trachea will be pushed to the opposite side. But if it's going to be lung collapse, segmental collapse of the lung, for example, due to any reason, foreign body or any endobronchial growth, the point is if you're having a segmental collapse or if you're having idiopathic pulmonary fibrosis, then the trachea will be coming to the same side. Now this I've said even in the previous videos as well, so I've not written it down, but I've tried to focus on some radiology volume-based parametrics or volume-based metrics which are related to the radiological findings that would be seen in a case of pleural effusion. And now we're going to focus on clinical findings. If a person is having, let me say, a lung cancer and is having a massive unilateral pleural effusion, it's going to cause an extreme amount of dyspnea. And because there's going to be fluid on one side, it's going to restrict the lung movement. So you will notice that the patient would be having an asymmetrical chest wall expansion. Whichever side there's going to be pleural effusion, the chest expansion would be limited. And then when you are going to be doing a percussion, either he will write the word dull, or if he wants to make it easier for you, he will write the word stony dull. And why did I say that? Is because dullness on percussion is what you get even in case of pneumonia. But in pneumonia, you will always read about bronchial breathing. In pleural effusion, no mention of any bronchial breathing. So stony dullness on percussion. This is in contrast to hyper-resonant percussion node. I have taught you hyper-resonant percussion node is a feature that's seen with respect to pneumothorax. But when it's going to be stony dullness and percussion, that would be with respect to pleural effusion. And then when you're going to check out the tactile vocal fremitus, the tactile vocal fremitus will also be reduced. The reason for this is that there is water over the lung, there's fluid over the lung, and therefore the vocal fremitus component is determined to be relatively reduced. As far as the tracheal shift is concerned, I have already explained to you that you will be getting a contralateral tracheal shift, but this is usually seen when more than 1 liter of fluid is present. So this would be relatively a late finding, and I would not suggest you to rely on tracheal shift neither for pneumothorax MCQ, neither for pleural effusion MCQ. Rather focus on the other aspects like point number 4 and 5 that I'm going to describe for this topic before you. And point number 4 would be very characteristic, because what's going to happen is that there is water over the lung, so the intensity of the breath sounds would be relatively lesser. So he will write words like diminished breath sounds, or instead of saying diminished, he might write the word inaudible. Now, I did not use the word absent breath sounds, because if I'm going to say the word absent breath sounds and absent air entry, then that's going to be suggestive of pneumothorax. And in pneumothorax, I also told you that there's going to be a hyper resonant percussion note, because there is air at positive pressure. So hyper resonant percussion node and absent air entry is pneumothorax. Whereas if he's going to talk about stony dullness and percussion, diminished breath sounds or inaudible breath sounds, that's going to be suggestive of pleural effusion. And obviously there would be some other hints as well. So let's look at some other hints. One of the hints would be that at the upper border of the pleural effusion, so I'll just go back in my diagram and just use an alternative color to highlight this. If you're going to be auscultating over the green area, that's where you would be having breath sounds which are going to be inaudible, or they're going to be diminished in intensity. But if you are going to reach the upper level of the fluid, at the upper level of the fluid, where I'm putting the blue marker at the moment, at the upper level of wherever the fluid is, if you're going to auscultate, you will be able to get a finding which is read by you even in topic of pneumonia, that is called as egophony. What do you mean by the word egophony is that you will be asking the patient to sit with his face away from you and say the word E again and again, alphabet E for England. And when he's going to see the word, he's going to say the word E, and you're auscultating the patient over the blue area that I was showing, that is at the upper level of the pleural effusion, it's going to sound like a A. It's going to be sounding like a bleating A, like the bleating of a goat, or like, Shah Rukh Khan in that Dar movie. I mean, I know that you guys would not have seen Shah Rukh Khan in his prime, but then Shah Rukh Khan in Dar movie, that bleating and that bleating of a goat, a kind of sound coming. So that's going to be E sounding as A. That's called as egophony. And pardon me if that did not rhyme well and did not explain the topic. All I'm trying to say is alphabet E, which is being pronounced by the patient while the patient is facing away from you. When you're going to auscultate, it's going to sound like an alphabet A. That's going to be something like a bleating of a goat or bleating of a sheep. That's what is called as egophony. And we read about egophony even in the topic of pneumonia. But in pneumonia, we have bronchial breathing, the most reliable. I've said that in pneumonia, multiple times, and I have to say that again to emphasize this data on your mind, that whenever you read the word bronchial breathing, normally in our chest, we have vesicular breathing, but bronchial breathing is a classical auscultatory finding of lobar pneumonia. Having said that, another feature which I can say at this moment, egophony is obviously an important part, but this point number 5, I would say, is maybe given in a question, may not be given in a question, and you would still be in a dilemma. Okay, what is it trying to say? Then another feature that might come to your rescue is the word pleural friction rib, though the point is, pleural friction rib would be seen in the early part of the disease. See, pleural friction rub can be differentiated from a pericardial friction rub in a sense that if you're going to ask the patient to hold his breath, pleural friction rub is going to disappear. Pericardial friction rub would be heard irrespective of whether the person is breathing or not breathing, but pleural friction rub can be differentiated from a pericardial friction rub. Simply tell your patient, ki sir, saans rok lo. Ask your patient to hold your breath, and when he's going to hold his breath, that's when pleural friction rub is going to disappear. Over and above this, I'm just going to use an alternative color to highlight, because point number 7 would tell you an alternative etiology as well. What I mean by alternative etiology as well is the fact that suppose I'm able to hear a third heart sound in the patient, or apart from third heart sound, if there is a bilateral pleural effusion present, plus there is going to be elevated JVP, it tells me the fact that the person is having congestive heart failure, which is contributing to a pleural effusion. These findings that I've written, specifically I would like to mention left ventricular failure contributes to bilateral pleural effusion. So along with these findings, if he's writing a S3 also, is writing an elevated JVP also, is trying to tell you that congestive heart failure is the cause behind development of this pleural effusion. And I'm going to write point number 7 once again before you, but this time I'm going to change the findings. Like suppose there's a question which is mentioning that the person is started to have extreme amount of weight loss, and apart from this there might be cough experienced by this person, there might have been hemoptysis which has been experienced, and sometimes there might be mention of digital clubbing as well. So it's trying to tell me that there is possibly a lung cancer which is responsible for development of pleural effusion. In fact, in majority of the previous years in the exam, both in FMG exam, I would say large number of times they've mentioned about this clinical information. I mean, clubbing they've not mentioned, but they mentioned a person presenting with cough and hemoptysis and cachexia, and then is mentioned regarding extreme amount of breathlessness and describe these findings like I've told you, that there's going to be stony dull percussion node, decreased vocal parameters, diminished breath sounds. And he said, what is the probable diagnosis of the patient? Simple. If he's going to give you history suggestive of a malignancy and then going to talk about all these findings, you will say this is suggestive of a malignant pleural effusion. Obviously, for confirmation of diagnosis, I will be doing thoracocentesis. That I'm going to teach on the subsequent slides, that what is the preferred site, what are the precautions to be taken, what are the indications to be followed for, or what is the primary indication for thoracocentesis. But at the moment, my focus is on the fact that if they give you these additional points, then that is a welcome information. And suppose I'm just putting a hash here to say, or slash here to say, that suppose the question is not mentioning cachexia, but he says that a villager came to a hospital, he is telling you that he's having evening rise of temperature, there is night sweats present. I mean, cough in anybody for more than 2 weeks in India. Along with that, there is night sweats, there is evening rise of temperature, there is a weight loss. He's trying to tell me that there could be tuberculosis and TB. Especially primary TB secondary TB will usually cause a cavitation, but primary tuberculosis, the Gons focus, can be subpleural and can result in development of pleural effusion once again. So the data in white is going to be the starting line of the MCQs. And the remaining information that I've written, stony dull percussion node, tracheal shift, diminished breath sounds, these are going to be findings in the later part, which will tell you it could be tubercular pleural effusion, it could be malignancy, which is responsible for pleural effusion. In fact, malignancy will cause extreme amount of breathlessness because it's usually a massive pleural effusion, or it could be heart failure, which could contribute to bilateral pleural effusion. I know a lot of data. I'm going to simplify that in the subsequent slides, but I've tried to focus on this particular slide on hardcore clinical issues that they would like to ask with respect to pleural effusion. It's very simple, guys. It's simply that you need to get the data imprinted into your brain and you would be through with respect to solving these questions. Now, in the light of these clinical informations, if they give me an X-ray like the one that I had shown you earlier, where there was a very classical concavity present, along with that, we also could pick up that blunting of the costophrenic angle, and we could pick up a hemithorax and the obscuration of the hemidiaphragm, I would say. So this X-ray is telling me that there is about more than 500 ml of fluid present with respect to the pleural space, and therefore the diagnosis of this person would be given as a right-sided hydrothorax. Now, I want you to focus on the X-ray, which is just adjacent to it, and you can notice that there is a convexity instead of a concavity like the one that you can pick up. This is also wide, but if you are going to get a convexity like this, please notice that in the superior or the X-ray on the left hand side, there is a concavity which is present. But with respect to the current X-ray, I am pointing towards a convexity. So considering that, my probable diagnosis, obviously I need to do a thoracocentesis, but if he gives me an information like this in the exam, only the X-ray is given, and he mentions a convexity, I'll say this could be a query right empyema. Obviously, this could be a loculated empyema. You cannot check out the loculation. So ideally, I would recommend to do a CT chest only so that I can pick up the loculi and the adhesions which are present, because loculated pleural effusion sometimes, if you're going to do a thoracocentesis and you're putting the needle at an area where extensive amount of loculi and adhesions are present, pus may not come out, a very less pus would come. So you will have to select the biggest pocket of pus and then go in for a thoracocentesis, which is ultrasound guided. But on the basis of this, I can say that this the image that is currently present, where there's a convexity present, Yes, there is fluid or liquid present, but the first differential in this case would be answered as a right-sided empyema in contrast to the right-sided hydrothorax on the X-ray, which I currently just marked at the moment. And we would now talk about thoracocentesis. I mean, where would you like to put in the needle? And as far as where would you like to put in the needle, whenever I talk about it in a routine class, most guys are able to tell me the site properly. That would be as low as possible. Like if we give you options like second space, fifth intercostal, second intercostal, fifth intercostal, seventh intercostal, eighth intercostal, then you would like to go as low as possible, because the lower you go, more would be the possibility of you hitting the fluid and aspirating a substantial amount of it. Because suppose if I'm going to put it in the seventh and the fluid level is just at the level of seventh or little below seven, I am going to put the needle in the pleural space, that's okay. But because the fluid is at a lower level, the fluid will not be able to come out. A very less amount of fluid might come, and that may not be sufficient for my diagnostic purposes. And I would not like to fiddle around with the needle much, because I don't want to cause a pneumothorax. As a result of it, he says try to put the needle in the lowest possible intercostal space. This should always be thoracocentesis, guys. Always is going to be ultrasound guided. This happened in Mumbai, that a doctor had done an intern. I think this was KEM and a medical college, and he had done a thoracocentesis which was done without ultrasound guidance. The patient developed a pneumothorax. We know that's a big time complication, and unfortunately this went to court, and the magistrate obviously, they put up adverse remarks against the hospital, and they were almost on the verge of canceling the license of these doctors who had done this procedure. Luckily it was a government hospital, so I'll not go into the case first further, but I want to tell you that had this been in a corporate hospital with a private practitioner and a big good practice, I mean, the guy would have had it. I mean, his practice would have big time impacted by the adverse, remarks passed by the honorable court, and that could have resulted in cancellation licenses, etc. So luckily these guys got away, but still, what I'm trying to tell you is always do it ultrasound guided, and you can use the backside. Like you are having that hypodermic needle, no, so you can remove the cap of the hypodermic needle and use the backside of it and press it hard into the skin. Like, if I'm using a pen, and if I make pressure over my skin, I can cause an indentation. So instead of using a pen or a pointed tip, what is recommended is that you can remove the cap over the needle, and then you can use the blunt side of that cap and press it hard on the intercostal area, and you can make an indentation in the skin, so that the radiologist will guide you where is the largest pocket of fluid present. So as far as the site is concerned, it's eighth intercostal space, as I've explained, usually between the eighth and the ninth rib. Try to answer it as low as possible. In the textbook, it is mentioned as a range. It is written as 7 to 9 space, depending on the decision of the doctor. What I have selected is 8th intercostal space as a single best answer. And then this 8th intercostal space, where would you be putting the needle? Do not answer mid-axillary line. Here the image is in front of you, and I take a live class, I say people making a mistake and answering it as mid-axillary line. Mid-axillary line is for chest tube, the triangular safety part that we study even in pneumothorax. But this time it's not going to be answered as the mid-axillary line. Rather, you will be answering that you're going to be putting the needle somewhere between the posterior axillary line. Listen to my words carefully. Don't straight away mark as posterior axillary. It is between the posterior axillary and the mid-scapular line. So you have to select a area between the two. That is, you see, you have anterior axillary, mid axillary, and posterior axillary. What I'm teaching you is you have to go even behind posterior axillary. So please remember, posterior axillary ke bhi piche, but before the mid scapular line. So inferior border of the scapula is what I'm talking about, and the posterior axillary line, and between the two is the side. Another way to remember this would be that you could be putting the needle about 6 to 8 centimeters. Obviously the radiologist is gonna tell you, I was saying that radiologists will focus on the biggest pocket of fluid, and you need to make an indentation on the skin in the intercostal space, and that's where you're gonna put in the needle subsequently. And then through that you can guide a gentle catheter as well, a pigtail catheter, and that will help in removal. So usually the site is going to be answered as 6 to 8 centimeter lateral to the spine. That is one way of remembering it. In the exam, he's going to make it a little more difficult for you by mentioning various lines like between mid-axillary and anterior axillary, or between mid-axillary and posterior axillary. You will say even piche and posterior to posterior axillary, that is between posterior axillary and the mid-scapular line. Also, next what I'm going to say is applied anatomy. I think everybody knows this, that the neurovascular bundle would be passing below every rib. So when you're gonna introduce the needle, whether you're gonna introduce the needle inside for local anesthesia or whether you're gonna be doing the proper procedure subsequently, the needle has to be inserted in the lower part of the, listen to my words carefully guys, you have to put the needle in the lower part of the intercostal space slash you need to put the needle above, listen to the words carefully, it is above this upper border. It is, the needle is just being put above the upper border of the lower rib. You know, in the exam, they'll make permutation combinations like lower border of upper rib, upper border of the lower rib. What I have told you at the moment is the dot that I put, that's gonna be in English written as upper border of the lower rib, and that would mean the lower part of the intercostal space. That's because I want to avoid any kind of injury to I mean, there's an artery present here, intercostal artery, intercostal veins. So I want to minimize the damage to the neurovascular bundle. Then what is the indication for thoracocentesis? Well, thoracocentesis is done in any patient with moderate to a large effusion if it's causing breathing difficulty. It would also be done for diagnostic purposes. I'll say that once again. If suppose somebody is having lung cancer, he's having a 1.5 liter fluid or 2 liters of fluid in pleural space, he will have breathing difficulty. So I need to go in for thoracocentesis. Or for that matter of fact, if I want to pick up tubercular, you know, it might be fluid, might be very less. But I want to prove if it is tubercular, I will have to do it a diagnostic thoracocentesis. So thoracocentesis is done for diagnostic purposes and therapeutic purposes. Therapeutic means relief of dyspnea. Now, in a broad way, he's gonna not write these terms in an MCQ. He will rather put it up in the following fashion: a sonographic parameter. I mean, if there's gonna be fluid in the pleural space, it's gonna push away the lung. If there's going to be fluid in the pleural space between the two pleura, that is visceral and the parietal pleura, it's going to push away the lung. Therefore, the radiological parameter to be remembered is free fluid separates the lung from the chest wall. See, there's pleural space and then after that is the lung, and between the two pleura is the fluid. So it's going to push away the lung. So the data to be remembered by you is, if the free fluid separates the lung from the chest wall by more than 10 millimeter, that is indication for thoracocentesis. In simple English, when I'm going to explain it to a non-medico, I'm going to say anybody who's having moderate to large hydrothorax or pleural effusion, if it's big, like in a lung cancer, it's causing breathing difficulty, yeah, we'll put in a needle and then over that catheter and we can drain the fluid. Or for diagnostic purposes, I can be doing a thoracocentesis, but in the exam, he would like you to remember what I've just said, that because the lung is being pushed away, so the gap between because the fluid is creating that gap. So if there's a free fluid that is separating the lung from the chest wall by more than 10 millimeter, it is an indication for thoracocentesis. The preferred site would be, patient would be sitting. You will ask the patient to cross his arms slightly like this, or he can just cross his arms like this and slightly lean onto the table. And the advantage of leaning onto the table would be one, that he'll, you tend to feel a little more, your shoulders become a little more relaxed if you lean onto the table. And another advantage is going to be that the lower border of the scapula will become prominent. So it will be easier for you to pick up the surface markings, and then you can subsequently, with help of aid of a radiologist, mark the site. Then subsequently you can clean the skin. The part preparation will be with chlorhexidine. This has been proved to be superior as compared to povidone iodine, and you don't need to wait for it to dry, unlike for iodine part. And then you have to give local anesthesia. When you give local anesthesia, you have to pull back the plunger and then gradually inject it slowly, and you will have to inject it even right up to the pleura. And you might have to even inject some amount of that into the pleural space as well. And while you are doing that injection, first you have to aspirate the pleural fluid. You have breached up, because your needle tip is sharp, so it will breach the pleura. The moment that you notice with that negative suction, that some pleural fluid has come into that local anesthesia syringe, you need to inject. I mean, you will go on injecting through the various muscles till you reach the pleural space, and some of that local anesthesia might even get injected into the pleural space as well. Would not cause any harm, but rather will anesthetize the localized, will anesthetize the local nerve endings present here, and will make the procedure, I would say, much more comfortable for the patient. So these are the practical aspects for thoracocentesis that you need to remember. And then they have asked regarding what is the maximum amount of fluid that can be removed per sitting. Now there are different guidelines for the same, but the British Thoracic Society guidelines is what I am quoting at the moment. I'm writing BTS, that is British Thoracic Society guidelines, is what I am quoting, that he says that not more than 1500 ml fluid should be removed in a single sitting. Now the question is, why? I mean, why can't we remove the entire? Suppose it is 2 liters. Why can't we remove 2 liters? What he has said is that because the lung was earlier getting compressed by the fluid, maybe the fluid was, lung was getting compressed by this fluid for maybe 2 days, 3 days, and even much more than that. So what he says is that the compression over the lung tissue also crushes the lung blood vessels and also causes mechanical stress on the capillaries. I'll repeat that once again. What he's saying is that because the lung is crushed by that fluid or is squeezed by that fluid, even the vasculature of the lungs gets injured by this pressure. And when you relieve this pressure, it results in development of leakage of fluid from the blood vessels. Those blood vessels were injured because of the shear stress. They were injured because of the physical trauma, the fluid pressing over the blood vessels of the lung. Now, when you relieve that pressure, it causes these damaged blood vessels to leak fluid into the alveoli. What I'm trying to teach you at the moment is what is technically called as re-expansion pulmonary edema, a peculiar term but worth its effort in the MCQ. Re-expansion pulmonary edema contributes to development of respiratory distress after doing a pleural tapping. One of the reasons for developing respiratory distress after pleural tapping can be, or thoracocentesis can be, pneumothorax. But suppose if pneumothorax is not in the options, then the second important reason why a patient can be developing breathing difficulty after you've done thoracocentesis is what I've explained at the moment, re-expansion pulmonary edema. The reason for this re-expansion pulmonary edema is mainly shear stress, the shear stress or mechanical stress on the blood vessels due to pleural effusion. You see, because the fluid is pressing on the lung from outside, it's also compressing of the lung vasculature. And he says this compression, if it's going to be present for more than 3 days, that's what they've usually determined in clinical studies, then there is a mechanical stress on the blood vessels. And because the shear stress on the blood vessels or mechanical stress is present, it will make the blood vessels leaky. And therefore, as I said, because the blood vessels will become leaky, the fluid leaks into the alveoli. In you and me, our capillaries are not going to leak fluid into the alveoli only if they are injured. The reason for mechanical stress, and therefore there would be pulmonary edema that will cause breathing difficulty. So now you know 2 reasons for breathing difficulty after you have done. Remember, patient came with breathing difficulty. No, patient was having lung cancer and he was having breathing difficulty. And after your procedure, he is having more worsening of that breathing difficulty. That's a cause of concern. Relative will ask you, sir, kya ho gaya? So you have to be aware of the 2 complications that I'm teaching you. One is a possibility of pneumothorax. So always do it ultrasound guided. When injecting local anesthesia, don't just inject. First try to, keep the plunger in a negative suction mode initially when you are going inside, and then you inject. I mean, when you're going, normally also when you give local anesthesia, you apply a bit of negative pressure on the plunger when the needle is going inside. So just need to follow that standard process of injecting local anesthesia, and then subsequently don't fiddle around with the needle much. It has to be a straight, clean process, which the path has already been delineated with help of the aid of a radiologist, and it's a clean process so that you can aspirate the fluid. And then in case there's a breathing difficulty, then 2 possibilities are to be considered: pneumothorax and re-expansion pulmonary edema. We will now study regarding transudative pleural effusion versus exudative pleural effusion. That is, the 2 varieties of pleural effusion are going to be discussed subsequently. To understand the transudative variety, we will just focus on what we studied in first year in medical school, that is Starling forces, not Starling law, not Frank Starling law. I'm talking about Starling forces. You are aware that on one side in the blood vessel, we will be having a hydrostatic pressure head, and the second side we will be having oncotic pressure. And due to the hydrostatic pressure and the oncotic pressure, the fluid moves out of the blood vessels. These blood vessels that I'm showing are with respect to the pleura, and this pleura, the capillaries in the pleura is from where the fluid will be leaking, and this fluid will then also come back due to the oncotic pressure which is afforded by the proteins. And one of the major protein which is responsible for oncotic pressure is albumin. The diagram here is trying to explain to you that we are having interstitial fluid or interstitial space, and in the interstitial space there is going to be pleural fluid present. This pleural fluid amount is decided by the fluid that comes in due to hydrostatic pressure and the fluid that goes back because of the oncotic pressure. And if there's going to be an imbalance between the two, then this pleural fluid is going to increase. Like hypothetically speaking, let me say if the hydrostatic pressure becomes more, then more fluid will be leaking into this area, and therefore the pleural effusion will become much bigger. And what you can see therefore is any patient having congestive heart failure, which is one of the leading causes of development of transudative pleural effusion, is going to cause excess, it's going to contribute to substantial amount of pleural fluid accumulation. It can be bilateral because pressure is going to be equally distributed across both the lungs. So transudative pleural effusion slash congestive heart failure always results in development of bilateral pleural effusion. Another reason why this can be happening is because the oncotic pressure is becoming lesser. And when I'm saying oncotic pressure is becoming lesser, it means albumin is becoming lesser. So what are the conditions where albumin will become less? One, where is albumin synthesized? Liver. And if liver is damaged due to cirrhosis, again the fluid will not be able to come back. I'm putting a negative sign here to say fluid is being produced normally. Hydrostatic pressure is normal, but if oncotic pressure is reduced, then fluid can't go back, and therefore cirrhosis will contribute to again development of pleural effusion. Another condition where albumin will be less is because of the urinary loss, and this urinary loss can be pretty substantial, more than 3.5 grams on a daily basis. So even nephrotic syndrome patients tend to have breathing difficulty. That would be a bilateral pleural effusion. At this moment, you are aware of total of 3 causes for transudative pleural effusion, and each one of these causes will cause a bilateral pleural effusion. That's going to be heart failure, cirrhosis, and nephrotic syndrome. Over and above this, you need to remember a mnemonic by the name of PSM. As a subject, you study PSM, you may like it, you may hate it, but we are going to use PSM mnemonic to remember a couple of other transudative causes of pleural effusion. That this can be a complication that can be seen with peritoneal dialysis. Understandable. Peritoneal dialysis, you are taking access into the peritoneal cavity, so no big deal that you can end up with the, you could be having ascites first, and then from anatomy you are aware that there are holes in the diaphragm from where the fluid can pass, the ascitic fluid can pass into the pleural space, and therefore there could be a hydrothorax as a manifestation. The next to be remembered would be superior vena cava syndrome, which is usually seen with lung cancer. And alphabet M is to be remembered for myxedema, which is associated with hypothyroidism. A large number of MCQs will simply ask you what is the leading cause for development of transudative pleural effusion. Then your answer would be given as congestive heart failure, specifically left ventricular failure, LVF. On the other hand, they might also love to ask the one-liner MCQ will simply say, what is the type of pleural effusion seen in myxedema lung? Hypothyroidism, myxedema. What is myxedema? Lymphedema. Lymphatic fluid again is related to the Starling forces only. So the main message is myxedema, which is seen in hypothyroidism, can cause lymphedema in the lung as well, and therefore blunting of gastrocnemic angle could be a possibility. Let us now focus on the right hand side with respect to exudative. Exudative, guys, is always about inflammation. Every time you're gonna read transudative and exudative, what should come in your mind? Hydrostatic क्यों होता है? It is because of pressure related issues. Hydrostatic is related to pressure related issues. On the other hand, or lymphatic fluid accumulation. But whenever it is exudative, it's always going to be inflammatory cause. Inflammation would always mean fibrin is present. In fact, this was asked in the recently concluded FMG exam. So simple, no? Exudative pleural effusion will be having, he did not write high protein. He said fibrin present, which will explain why adhesions can develop, which can explain why I was saying loculated pleural effusion. कि उसमें patches, pleural effusion is in an area, then in an area, and there are adhesions present. And therefore, when you put in the needle, you might be putting the needle in the small area. From a little bit of fluid will come, remaining because of adhesions, remaining fluid will not be able to come. That is why I was saying select the biggest pocket of wherever the fluid accumulation is present. So exudative is always because of infection. And the first thing that most guys answer is TB. So that's okay for India. That's okay for India, but don't answer TB as the leading cause for exudative pleural effusion. A lot of brilliant chaps make that mistake. Your answer is simple pneumonia. What I'm trying to teach you is that people with pneumonia can be simultaneously having a pleural effusion as well, and therefore I'm going to use the word parapneumonic effusion, that my patient is going to be having a combination of pneumonia and then a pleural effusion as well. And if I do not treat this aggressively, there's no big deal that there could be development of pus in the pleural space, and this would mean the person will require a chest tube. You might even subsequently require surgery to break down those adhesions. There might even be a requirement of thoracotomy in these patients in future, which a procedure which is called as decortication, where you break those adhesions which are causing that loculated pleural effusion with pus present. So the main message is exudative, the leading cause should be remembered as pneumonia, whereas for transudative, the leading cause is congestive heart failure. Transudative effusions are most of the time bilateral, but exudative, they can be unilateral or they can be bilateral. I repeat that again. Pressure is equally transudative, matlab kabhi bhi padhoge na, that basically means that there is going to be a problem with respect to pressure. Pressure is equally distributed, so therefore there's going to be a bilateral effusion. बट एक्सुडेटिव डिपेंड करता है भाई, जैसे टीबी है तो टीबी बोथ साइड पे तो यूजुअली होता नहीं है ना, और देयर इज गोना बी लंग कैंसर इज गोना बी ऑन वन साइड ओनली. सो द मैसेज इज इफ इट्स गोना बी pneumonia, if it's going to be lung cancer, if it's going to be tuberculosis, these all are examples of exudative pleural effusion. It may not be a bacterial pneumonia, it can be viral pneumonia as well. The important entries to be remembered on the right hand side, I'll use a different color pen to be remembering that, would be one, rheumatoid arthritis. Please do not mix this with rheumatic arthritis. Rheumatic is with rheumatic fever where there's a child and he'll have recurrent sore throats with group A beta hemolytic streptococcus. I am talking about erosive arthritis where there would be a female with pain in the PIP, proximal interphalangeal, metacarbophalangeal wrist joints, small joints of the hand would be affected, and that will cause deformities in the hands like swan neck deformity. Yes guys, the same rheumatoid arthritis that causes a swan neck deformity is responsible for causing rheumatoid nodules. These rheumatoid nodules could be in the lungs, and the inflammatory nodules will break down because rheumatoid arthritis is an autoimmune disorder. So that autoimmunity means inflammation, and therefore these nodules will break down to produce an exudative pleural effusion. So remember, rheumatoid arthritis should be remembered as an exudative pleural effusion. The next cause to be remembered is pulmonary embolism. Very neglected fact, in fact, most of the time. Pulmonary embolism, yes, the same that you read with deep vein thrombosis, no, that there's going to be immobilized patient and then there's going to be clot in the legs and then it's going to go towards the lungs and cause massive pulmonary embolism. The same pulmonary embolism could be responsible for a pleural effusion that might be noticed on an X-ray, and this pleural effusion is again inflammatory in nature. So embolism is what is to be remembered. The next point to be remembered is Dressler syndrome. Now, Dressler syndrome has been taught to you as a late complication of myocardial infarction. It causes a post-myocardial infarction pericarditis. Post-MI, it's a late complication of myocardial infarction. It contributes to development of post-MI pericarditis, but then it can also contribute to development of pleuritis as well. It can cause a pleural rub. So on the right hand side, I would like you to remember red as a mnemonic. On the left hand side, I would like you to remember PSM as a mnemonic, over and above the common causes which are written superiorly. In fact, let's quickly do a revision with respect to transudative versus exudative pleural effusion. And my suggestion for you guys at this junction would be that this that I'm saying at the moment should be imprinted into your brain right now, right here. Transudative is due to pressure. Pressure is equally distributed. So all the causes that are written for the transudative variety, they all of them are these causes that are written are going to be bilateral effusions. Heart failure, nephrotic, cirrhosis, bread and butter kind of MCQs for you, but you can go beyond this, and that's where you need to remember PSM mnemonic for the left hand side. That's going to be peritoneal dialysis, superior vena cava syndrome, and mixed edema. Especially mixed edema needs to be given that due importance in a sense that it would be one-liner question and people usually go wrong on that. For the exudative variety, one of the important ones to be remembered is pulmonary embolism. Apart from the red mnemonic is there, but I usually find once I've taught no rheumatoid arthritis, rheumatoid nodules, autoimmune disorder, people get a hint, okay sir, you told autoimmunity, so inflammation present, that is why I can crack it, it's exudative. Same is the issue with Dressler. Dressler is autoimmune. Dressler syndrome is a autoimmune post-MI pericarditis / pleuritis. So again, the moment I say autoimmunity, it gets registered. But embolism part, there's there's sometimes people tend to neglect it. And then pulmonary embolism again would be related to clot formation. It would be related to inflammatory changes, and that is why vein inflammation present. So the type of effusion that is seen here from the Leitz criteria also the exudative variety. I would like to rate this as an important part of the discussion from fact-based perspective, because prior to this was clinical information like this particular slide, I would say, the clinical findings of stony dullness, The other associated findings I've explained, the radiological ones, and then the site for thoracocentesis. I mean, this was hardcore clinical manifestations that I was describing with respect to pleural effusion. But the ones that I've explained on this particular slide are more fact-based. They're more on etiology. They're more on pathology of the disease, why it evolves into a pleural effusion. Next up is Light's criteria for diagnosis of pleural effusion. They help us in differentiating between transudate versus an exudate. So let's look at the first one. That would be that in the numerator, you want to take up PF means pleural fluid. So in the numerator, you want to take the pleural fluid protein and you want to divide this by the serum protein value. And in case this value is more than 0.5, the mathematical ratio, it goes in favor of an exudate, the inflammatory part, because every time there's inflammation, protein or fibrin would be elevated. Next, what you're going to take into consideration is LDH values in the pleural fluid. So the numerator, you want to take up pleural fluid LDH. In the denominator, we are going to take up the serum LDH values. And if this ratio is more than 0.6, it is again suggestive of exudative nature of the fluid. Now, instead of writing like this, value more than 0.6, it can also be written as pleural LDH values more than, I mean, look at the description that could be written. If you look at it mathematically, 2 by 3 is also going to be 0.6 only. So it will be written as pleural LDH value more than 2/3 of the upper reference limit or upper limit in the serum. And these are like 3 Light's criteria that you need to remember. And the main message is that in a question, if all of these values are given as more than, though at least one of these criteria should be present. He says to say it is an exudate, at least one criteria out of these should be present to call it an exudate, but more the merrier. I mean, let me say, suppose you get a report in which both things are elevated, that protein is also elevated, LDH is also elevated, or just for the sake of an MCQ, let me say he gives you these 3 data and all of them are mentioning more than, you will say it is an exudate. But suppose these parameters are less than, then you will think in terms of a transudate. The main message is Light's criteria are used to differentiate whether it's going to be a transudative pleural effusion versus it is an exudative pleural effusion. Transudative is always because of pressure, and pressure is transmitted bilaterally. Exudative may be unilateral, may be bilateral. It's mainly because of inflammatory changes that these following arrows you are requested. You are requested to remember them. And then he also puts up a rider. He says that these criteria are not 100% accurate. There is a high probability that these criteria can misidentify 25% of transudates as exudates. So these are okay. I mean, they have been present for a very long time, but we should also be checking other parameters, like pH or glucose values, because as I've explained to you that if it's going to be right in the beginning, I told you the pH of the pleural fluid 7.60 to 7.64. So I right in the beginning said low pH indicates possibility of an exudate. Obviously, I'll rely my diagnosis for any infection-based exudate to be based on gram stain and on a culture, but then misidentification is possible with Light's criteria. It can misidentify 25% of transudates as exudate is what he mentions towards the end. But yes, these criteria do help us in identifying the etiology or the nature of the disease. Now, the next point that he says is that suppose these criteria are telling you that it is an exudate. Suppose the top 2 criteria, pleural fluid protein divided by serum protein is more than 0.5, the LDH ratios are more than 0.6. If it is an exudate, what are the additional tests that should be done? That the additional test to be done is pleural fluid glucose. And if pleural fluid glucose is given to be less than 60, then what are the possibilities to be considered? The first possibility to be considered is malignancy. After malignancy, obviously, it could be infection, it could be in the form of empyema, it could even be rheumatoid arthritis. So 3 causes where I've told you where pleural fluid glucose will be less. Please listen to this carefully, guys. Again, pleural fluid glucose is not a part of Light's criteria. Only if the top 2 parameters are like more than 0.5, more than 0.6, then the next thing to be checked is pleural fluid glucose. But the main message is that glucose is not a component of the Light's criteria. I've said that again and again because there was a question in which he gave these various permutation combinations of pleural fluid protein and LDH values. And people got confused by saying that which one should I select, sir? He's giving us mathematical based values. The trick in the question was that in 3 options, he was mentioning protein, sugar in various values. And in the one last option, he was mentioning protein and LDH values. So they did not expect you to remember exact mathematical values. All you had to pick up was that sugar is not an initial component, as I explained, and you had to select only the parameter in which, I mean, doesn't matter what are the mathematical values, even if you're not able to remember it, chalega. All you need to remember is what is a component, what is not, and only if it is determined to be more than zero point 0.5, zero point 0.6, that is when you check the glucose values. And if glucose is less, then malignancy, inflammation, rheumatoid arthritis are to be considered. Apart from this, we'll also check up the pH. We are going to send the sample for gram staining so that I can pick up the etiology. I'll also get a culture done. There is a possibility culture may turn out to be negative as well. Gram stain may turn out to be negative as well, because it's not always about an infection. It could be a cancer. So I'll be able to, I can do a centrifugation of this pleural fluid, and in the sediment, I can pick up cancer cells. Cancer cells would be having intense basophilia. The nucleus will be bigger. So pathologists will tell us that malignant cells have been detected. Or mesothelial cells like mesothelioma. You read about association with asbestosis. That is where there could be mesothelial cells present. There could be pleural plaques present. So I'm going to talk about asbestosis in a while, the mesothelioma part in a while. But the main message at the moment is to tell you that pleural fluid sugar, as a test is done after the Lights criteria, are going in favor of an exudative pleural effusion. Having said that, let's now look at a couple of peculiarities which are to be remembered, and these are very standard one-liner questions. Every time you read about adenosine deaminase levels in the pleural fluid, this would be suggestive. I'm not saying confirmatory. Obviously, I need to do a CB NAT for that. TB updated video is already present in the later part of this pulmonology section, so go through it. But then elevated pleural fluid adenosine deaminase levels are suggestive of possibility of a tubercular etiology for pleural effusion. The next one is even more simpler, that if there is going to be pleural fluid that's going to be having N-terminal pro-BNP, that is B-type natriuretic peptide, it is suggestive of the fact that person is having heart failure as an etiology. And if he wants to make it more technical, he might say that which side of the heart will fail to produce a bilateral pleural effusion. The answer would be left ventricular failure. As I've explained to you that if it's going to be an acidic pH, glucose is less than 60, there's a positive gram stain and the culture is also positive, then in those circumstances, it means that the person is having empyema, which is pus in the pleural space. This fluid can dissect and can come even below the skin, producing a subcutaneous swelling that is called as empyema thoracis. And I don't want that to happen. I mean, the pus can navigate across the soft tissues and can come even in the subcutaneous tissue, producing a fluctuant swelling in the lower part of the chest. You read that as empyema thoracis or empyema necessitans. Therefore, for the treatment of empyema, you will obviously have to give antibiotics, because you see, antibiotics, you are aware, have a horrible penetration into pus. So whatever I do, I have to give antibiotics. But from the treatment perspective, what I need to do in this guy is, apart from antibiotics, I have to put in a chest tube. The chest tube by default will always be put in the fifth intercostal space. In the mid-axillary line, this fluid, the chest tube would be put in the triangle of safety using the standard precautions, and it will start evacuating the pus. But because of the high fibrin component, there is a high possibility that this fluid will clot and the tube will get blocked. So he also says that you have to instill in the tube. Listen to this point very carefully. He says that you have to put in a chest tube, but you have to do installation in the chest tube of two products. And one of them is going to be TPA, that is tissue plasminogen activator. I mean, traditionally we read about TPA with respect to thrombolysis in stroke, or we read about TPA with respect to thrombolysis in ST elevation MI. Though nowadays in MI we don't do thrombolysis, ST elevation MI, we do a percutaneous coronary intervention or PTCA. But here we are using LTAPLACE installation in the tube. And the second product that would be present along with TPA would be deoxyribonucleases. The basic point is that I want to prevent the tube from getting blocked, and if I'm able to do that and evacuate the pus, then antibiotics would be able to act. So the main message is you have to put in a chest tube and installation in the tube of TPA plus, in fact, both of them, TPA and deoxyribonuclease, that will prevent the tube from getting occluded. There's another approach which we can be using for management of these patients, which is going to be a thoracoscopy. I mean, nowadays we have this small pinhole camera based devices which can be installed into the chest of these patients in case it's a loculated empyema. Because if it is a loculated empyema, listen to this word again carefully, that if adhesions have already developed, you put in a chest tube in one particular area, it will allow that pus to come out, but then the pus will stop coming because adhesions will maybe be preventing a large chunk of pus to come out. So what you're gonna do in those circumstances is that you're gonna break those additions. So point number two that I've written on the board at the moment is valid for a loculated variety of a empyema. Apart from that, in some cases, we might even have to go in for surgery, that is thoracotomy, where decortication might be done. So open, I mean, you might have to, in the later part of the illness, might have to go in for a thoracotomy in these patients also. So per se, I can say empyema is a complication of a pneumonia. Had antibiotics been started at an appropriate time in appropriate dosages, the kind of deterioration that I've described at the moment could have been prevented. Moving towards the end of the video, in case it's a malignant pleural effusion, such a huge effusion like the one that I've currently shown here, it's contributing to severe amount of breathlessness in a patient, and therefore the term that will be used to describe, because the breathlessness will worsen whenever he will turn to one side. You see, I'm not teaching at the moment orthopnea, which is breathlessness, which is worsening in supine position. What I'm saying is that the breathlessness of my case is getting accentuated every time he will turn towards one side, that is lateral decubitus position. So the main message is that per se, with respect to pleural effusion, we can be having multiple possibilities. And one of them, apart from, from the exam perspective, that he can use this word only, that is trypnea. Obviously, I mean, when I say multiple possibilities, there he can usually talk about clinical findings here, like there could be a tracheal shift, there could be decreased intensity of breath sounds or inaudible breath sounds, that's stony dullness and percussion. But over and above this, he can mention about trypnea. And before I go forwards, I also want to say about a term that I've said in cardiology, that is platypnea. Platypnea basically means that the dyspnea of the patient is going to be accentuated in an upright position. When your patient is going to sit up, that is when the platypnea component is going to become much more prominent, and this is usually encountered in atrial myxoma. That is one. The second condition where platypnea component has been described is hepatopulmonary syndrome. Hepatopulmonary syndrome I have explained in the topic of liver cirrhosis. So a bit of miscellaneous information at the moment. Platypnea is when the breathlessness worsens in upright position. Trypnea is when the breathlessness increases in lateral decubitus, and then orthopnea to aapko aata hai, right? Heart failure, that's the breathlessness that is accentuated in supine position. So malignant pleural effusion will cause this, and for treatment of this chap, I obviously will remove this fluid. I can put in a chest tube, gradually evacuate this fluid. I'll not evacuate whole of the fluid. I'll put in a chest tube, evacuate maybe 500 ml today. Then maybe the next day another 500 ml, or maybe the next day I can go up to 700. So gradually, suppose there was 2 liters of fluid, I will be able to evacuate every single drop of fluid. But the problem with the malignant pleural effusion is recurrence. It is gonna come back. The breathing issues are gonna come back. And it's not that every time you're gonna put in a tube and you're gonna evacuate this fluid, it's gonna be emotionally a very traumatizing process for the patient. So what I'm gonna do at this point of time is that obviously I will evacuate the fluid. But then after evacuation of fluid, I'm gonna inject doxycycline into the pleural space. That doxycycline, what it is gonna do is it will cause development of adhesions. I'm not showing on this side, I'm showing on contralateral side. I want adhesions to develop between the visceral and the parietal part of the pleura. If I will deliberately cause these adhesions to develop. Earlier I was breaking adhesions, no? In loculated empyema, I was breaking adhesions. Now I'm saying I'm deliberately causing adhesions to develop between the two layers of the pleura. The objective of mine is to obliterate the space, because if the space is over, if the fluid, the fluid can't come back. So pleurodesis with doxycycline. Pleurodesis with doxycycline is one of the important approaches that can be used for management of these patients. Doxycycline would be acting as a sclerosing agent and would contribute to this manifestation. In place of pleurodesis, another approach that can be done is thoracoscopy again. And you are sending in a camera, you're sending in a device in the chest. And when you're doing this thoracoscopy, like we do upper GI endoscopy, we can do thoracoscopy as well. And along with thoracoscopy, what we can do is rubbing of the pleura till it bleeds. We deliberately are rubbing the pleura. We are trying to cause an abrasion. And this pleural abrasion basically means that you are causing bleeding to occur on the surface of the pleura, minimalistic amount of bleeding, but that will cause fibrin to be coming up there, and that will cause again adhesions to develop between the two layers of the pleura. So thoracoscopy with pleural abrasion is an alternative strategy which can be used for management of a malignant pleural effusion. In routine MCQs, he might just say the word pleurodesis. Meaning of the word pleurodesis is that there is additions used with developing on administration of a drug. Whereas in the inferior one, I said you are giving mechanical, you're doing mechanical rubbing of the pleura using thoracoscope, and that's going to cause local bleeding, and that will contribute to development of subsequent adhesions in this patient. So the main message is malignant pleural effusion has a tendency for recurrence and would be seen with a peripheral lung cancer. One of the leading cancers that can cause a malignant pleural effusion is the commonest lung cancer. The commonest lung cancer, as you're aware, is adenocarcinoma of the lung. Having said that, I next talk about mesothelioma, which is seen with asbestosis. But today we are talking about it not because it is seen with asbestosis, but because it can cause a pleural plaque formation. It can cause a pleural calcification. Because pleural effusion is the topic. So pleural plaque formation, pleural calcification is seen with mesothelioma. And mesothelioma is a cancer. It's not the commonest cancer, but it is the characteristic cancer which is associated with asbestosis. And you're aware of that from even your PSM, that asbestosis will usually be seen in people who would be, working in a shipyard or would be working in a cement plant, and can end up with manifestations even 20 years later. I mean, asbestosis, he might have worked in a shipyard 20 years ago, but manifestations can develop, much, even 20 years, unlike in silicosis. Silicosis manifestations will develop early. I mean, within a few years itself, the person will be unable to work, but asbestosis manifestations can develop relatively later. Then, as far as the type of effusion in pulmonary embolism is concerned, I've already explained to you. We discussed a mnemonic red, and there the E was pulmonary embolism, so it's an exudate. And for chylothorax, I mean, there is chyle. What is chyle? Chyle is lymph. It is lymph in the thoracic duct. So chylothorax would be milky white fluid on thoracocentesis, which will be having high level of triglycerides. Usually the concentration of triglycerides would be more than 110. So the main message is, if there is going to be damage to the thoracic duct, that's when chylothorax can occur. And why would there be damage to thoracic duct? Then it could be post-operative. I mean, this person underwent some chest surgery, and post-surgery there could be trauma to the thoracic duct. This could contribute to the chyle, which is being transported upwards, resulting in that, the chyle is transported by the thoracic duct. And then, where does thoracic duct start from? Thoracic duct starts from the intestine. It would be transporting chyle, which contains chylomicron. And then it's going to enter into the left intrajugular vein, where it meets with the subclavian vein. I mean, the end point of thoracic duct is veins, that is intrajugular vein meeting with the subclavian vein. You know that from anatomy. It starts from the intestine, as I've said. And why I've drawn this crude diagram is to tell you that there could be tumors that could be damaging the thoracic duct. Lung cancer can go into the thoracic duct and damaging the thoracic duct. So even mediastinal tumors, not only trauma or surgery, it could be mediastinal tumor, because sometimes they might just say trauma. But trauma, I don't mean a road traffic accident, but trauma, obviously it can be. But what I mean most of the time is trauma which is seen post-surgery, that thoracic duct was injured during chest surgery and that resulted in chylothorax, or it can be a mediastinal tumor as well, which could be contributing to it. For the management of chylothorax, we will have to put in a chest tube, but the drug, if he says, would be octreotide, which has been shown to decrease the amount of this triglyceride component and the fat loss, which can cause nutritional deficiency in these patients. We will have to put in a chest tube, but subsequently he says the main treatment for this would not be a chest tube, because it will keep on coming once the injury is there. So what we need to do is we need to fix the damage to the thoracic duct, and therefore thoracic duct ligation is the main treatment for this condition. Please remember, in chylothorax, initially what you're gonna do to relieve the breathing issues in a person that could be coming up, you can be putting in a chest tube and give octreotide. But then how do you fix the problem permanently? That is because of the trauma to the thoracic duct, either caused by the surgeon, iatrogenic, or caused by because of the tumor. It needs to be fixed by using thoracic duct ligation. Now, especially with respect to hemothorax, this is a question which is asked even in surgery, that if you put in a chest tube, then how much collection more than per hour is present, and the nurse of yours should alert you that you need to go in for an intervention. Then remember, in hemothorax, if the drain amount in the underwater seal is more than 200 ml per hour. Remember this value, guys, that in hemothorax, if the amount of bleeding in the bag is more than 200 ml per hour, the bag is the underwater seal bag I'm talking about, then you need to go in for intervention. I mean, the surgeon needs to fix this either by going in for open surgery, that is thoracotomy, or nowadays instead of going in with an open surgery once again, what we can go ahead is using angiographic approaches, that we can identify the bleeder and then we can go in for an angiographic coil occlusion as well. Well, the approach that we are using here may not be available in some hospitals, and we might have to go in for open surgery as well. But the main aspect to remember for hemothorax, though it's taught in surgery also related to trauma, is that if the drain amount is more than 200 ml per hour, intervention by the surgeon, I mean, the surgeon has to be alerted and intervention has to be done depending upon whatever is the facility. Then is a question integrated from OBGY, Meek syndrome. Meek syndrome is seen with benign ovarian tumors, and usually the benign ovarian tumors with which Meek syndrome is seen are fibroma or thecoma. Along with that, there can be presence of ascites, that is fluid in the peritoneal cavity, and there would be pleural effusion, and usually this would be a right-sided pleural effusion. Now, why it is right-sided? I get queries on that. So the main message is the reason for this right-sided pleural effusion is that the holes in the diaphragm which are present are more on the right hand side as compared to the left hand side, which is why the fluid in the ascitic fluid, which is reactive fluid to the tumor, can leak from the peritoneal cavity into the pleural cavity as well. Then the same holes that I was talking about will also explain the term hepatic hydrothorax. The meaning of the word hepatic hydrothorax is that cirrhosis patients will also subsequently end up with pleural effusion. And one of the reasons for this can be leakage of fluid, because cirrhosis patients will have ascites, and the ascitic fluid will then leak through these holes in the diaphragm and can contribute to development of hydrothorax or pleural effusion as well. I repeat that once again. Hepatic means that there is a problem in the liver, and the problem in the liver is that this guy is an alcoholic, so he has damaged his liver, he's had alcoholic cirrhosis, he developed ascites. But ascites वालों को pleural effusion भी हो जाता है. तो query यही है कि भाई how is it possible that an ascites patient with that big tummy is having a pleural effusion? Well, via the holes in the diaphragm, the fluid can be passing, and then we have bloody pleural effusion apart from TB, apart from trauma and bleeding diathesis. I mean, I'm not writing trauma, understandable. I'm not writing bleeding diathesis like warfarin toxicity, understandable. Bloody pleural effusion can be seen with TB. It can be seen with lung cancer, and it can even be seen with the mesothelioma as well. So these are a couple of causes where we can be having a bloody pleural effusion as well. These are the details for this topic that you need to remember. It took a while to cover because the slides that I mentioned, the subsequent ones are more of that miscellaneous kind of data with overlap with surgery as well. The hardcore information in this topic is this particular slide. Most questions, the clinical ones, would be based on these examination findings, and then a radiological finding which tells you that you're dealing with a pleural effusion. So keep the pressure on, keep learning new facts every single day, and you're gonna be much more wiser. As I say, keep hammering.